Hello everyone, welcome back to today's class. So today we are going to continue our discussion regarding neurology. So let's see. I'm recording and let me open PDF and let's go. Good. So today's topic is going to, my main task for today is to finish up the physiology of the brain at least. And hopefully we'll be able to speak about some of these subjects here. But mainly we have to finish up the physiology of the brain. So yesterday we spoke about the cranial nerves, but we did not discuss in details what each one of them do. So there is many ways to memorize these. I highly prefer studying each of them individually, okay? It's up to you how you learn them, but you must master them. Just keep in mind that some of these nerves are considered to be like parasympathetic nerves, and some of these nerves are considered to be like motor nerves, solely motor, and some of them are sensory and some of them are mixed. Just a quick note, 1973. These are the cranial nerves that are parasympathetic. Cranial nerve number 10, 9, 7, and 3. Okay. Let's see. Olfactory nerve, cranial nerve number 1. I want you to know one thing about it. Regardless of the fact that it's called a nerve, it's not actually a nerve. It is an outpouching of the CNS into basically the olfactory bulb. So what do you think? Since it comes from the CNS, will it be covered with Schwann cells or oligodendrocytes? Oligodendrocyte, absolutely. So keep in mind that the myelination process, in case of the CNS, it happens because of the oligodendrocyte, while in case of the PNS, which is the peripheral nervous system, it's going to be from the Schwann cells. So cranial nerve number 1 and 2, both of them comes directly from the brain. So both of them have myelination from the oligodendrocyte. So logically, guys, if a disease affects only the CNS, the myelination of the CNS, like multiple sclerosis, do you think he will have affection of a cranial nerve number 1 and 2? If a disease only affects the CNS? The answer is absolutely yes. Why? Because they are considered a part of the CNS. Okay, so the olfactory is responsible for smell. Only cranial nerve without thalamic relay in the cortex. Remember, all of our sensation must go through the thalamus except smell. That makes smell highly associated with our emotional status, such as happiness, depression, memories. When you smell that cake that your grandma used to make, you will have memories about that place. You know, when you smell that perfume of that lady, it can remind you about somebody. If you smell bad stuff, it also have an association. Okay, so olfaction goes directly to your brain. It does not go through the thalamus. So it goes directly to your limbic system and to your memory. Okay, so obviously it's sensory. Some say marry money, but my brother says big brain matter more. Okay. So the next one is optic. Optic is also sensory, as you can see, and it's for sight. There is a lot to speak about regarding this one. Its time will come. The oculomotor nerve is responsible for the movement of the muscles of the eye. Keep in mind that this one, and this one are responsible for the movement of the eye. So that's cranial nerve number 3, 4, and 6. Cranial nerve number 3 is the most important though. Why? Because all around your eye, if this is your eyeball, you have one muscle here called superior rectus, inferior rectus, medial rectus, lateral rectus, superior oblique, inferior oblique. you notice something. There is 6 muscles that controls the movement of your eye. The word rectus means straight. Remember, rectum means straight. So when I say rectus muscle, it means it's a straight muscle. While oblique muscle, it's like this. It's going like this in an oblique fashion. Okay, so the oculomotor, cranial nerve number 3, is for eye movement, which involve superior rectus, inferior rectus, medial rectus, and inferior oblique. You are like, okay, so that's 4 out of 6. What about the other 2? The other 2 are totally supplied by other stuff. So cranial nerve number 4 supplies the superior oblique, which is this one, okay? And the abducens supplies the lateral oblique. And that's it. That's all 6 muscles of the eye. I repeat, you have 6 muscles of your eye: superior, inferior, medial, and lateral rectus muscle, and superior and inferior oblique. Speaking about the superior and inferior and the medial rectus, all of these are supplied by the oculomotor nerve, in addition to the inferior oblique. However, when we speak about the lateral oblique, it's abducens. Abducens. The name is suspicious. Abducens. It sounds like abduction, right? And that's true actually. That's the function of it. The abducens. Abduct the eye. So it's going to be supplying the lateral oblique. Okay? The lateral oblique. Good. So let's take a look at the next thing. So the next thing says something like this. The third cranial nerve, is it parasympathetic? Just remember the mnemonic I told you. Is it parasympathetic? Yes, because of the mnemonic I told you. 1973. Cranial nerve number 3. 1973. So it's a 3, so it's parasympathetic. 7 is parasympathetic, 9 is parasympathetic, and 10 is parasympathetic. If you forget, just remember somebody who was born in 1973, some major war, some major event that happened in your country. Okay, pupillary constriction, when the pupils become small. The other word for that is meiosis, okay? Meiosis is when the eye becomes pointy. Mydriasis is when the eye becomes big, okay? I mean, to be more exact, that your pupil becomes big. So pupillary constriction, sphincter pupilla, you're like, wait a second, why it's making my pupil small? Okay guys, when you are resting and digesting, parasympathetic nervous system is activated. Would you like your pupils to be super big so you will be observe the light so you can survive and escape from the lion? Or they can be small and relaxed and you can just chill and sleep in the bed? You need them to be small and relaxed. You don't really care, you're just relaxing. That's parasympathetic nervous system active in that case. So that's why you have a pupillary constriction, because of the parasympathetic nervous system predomination. Sphincter pupilla is going to be affected, which is a type of muscle located near your pupil that leads to the pubilloconstriction. Pretectal nucleus and Edgar-Westphal nucleus and the muscarinic receptor are associated with this. How they are associated with this whole topic will be explained in ophthalmology. You must understand what is Edgar-Westphal nucleus of the midbrain. You must know what is the why the pretectal area matter, what is superior colliculus, and others. But for now, just know that they exist. Accommodation. What is accommodation? Guys, when I bring an object and I move it closer to your eyes, and your pupils were initially big like this, and I'm moving an object that is here, I'm moving it closer to your eyes, what will happen to the size of your pupil? It will constrict, exactly, it will become smaller. The closer it is, the smaller your pupil. The furthest it is, the bigger your pupil. So that's a way of your pupil to accommodate for basically the this type accommodation of the eye to be able to visualize normally the object you are trying to show it for it. Eye opening with levator papilla is also mediated by the oculomotor nerve. So if the patient is unable to basically open his eyes, they will be always kind of ptotic. What is ptotic? Look. So the eye will always be kind of, you know, dropping. Exactly, that's the word I was looking for. So you can see how it's dropping the eye. Ptotic eye. Yep, like this guy, ptotic. Why? Because the levator muscles is dysfunctional. Okay, so it sounds like he's motor and parasympathetic. This nerve, I mean. The next one is the trochlear nerve, cranial nerve number 4. It controls the superior oblique. Okay, and by the way, just for the sake of fun, let's try to draw the superior oblique alone here, and this is the muscle, and it is attaching to the back of your eye socket, of course. So if I constrict this, if I just constrict it, what will happen to the eye? Will it look up or down? Up, absolutely. So when you constrict it, it's going to pull the eye like this, which is going to make you look upward. Okay, so yeah, trochlear nerve, eye movement, superior oblique, but the superior oblique is actually quite tricky. It's not as easy as you think. So we said when we spoke about superior oblique, inferior oblique, medial oblique, all of these were I'm sorry, superior, inferior, and medial rectus, not oblique, and the inferior oblique. All of these were important. But there is something interesting here. All of these are supplied by the oculomotor, right? The rectus direct a movement towards the side. So the superior rectus move the eye upward. Inferior rectus move the eye downward. Medial rectus move the eye medially. Lateral rectus move the eye laterally. But what about the inferior and superior oblique? Well, that's the trick. The superior oblique move the eye downward. The inferior oblique move the eye upward. I know that it sounds messed up, but just memorize it for now, and I promise you I will show you exactly how that works. Again, superior oblique, tilt the eye downward. Inferior oblique, tilt the eye upward. So that's my mistake here. The superior oblique is going to tilt it down, okay? So if it's not functional, can the patient look down, tilted down his vision? In case of a trochlear nerve dysfunction? No. Can he go down the stairs? That's the trick. In the USMLE, they will tell you about somebody who's like, when going up the stairs, no problem, but when he's trying to go down the stairs, he always cribble on himself and fall. Because he cannot look down. That's a trochlear. Nice. Okay, good. So trigeminal nerve. Oh no, forget about trigeminal nerve. I'll go back to him. Let me just finish with the eye muscles. So the abducens nerve, it's a cranial nerve number 6. And remember, when we speak abducens, it's abduction, which is basically you are looking away. You are moving your vision away. So abducens, you are looking to the lateral side, basically. If you forget about it, just look at the B and the D. They are facing against each other. So you are looking away. That's lateral rectus, and it's looking away. So if that was dysfunctional, can you look laterally? Nope. So let's say that you have these two eyes. Now the abducens is dysfunctional. Okay, this is the right eye of the patient, and this is the left eye of the patient. If the right eye of the patient abducens nerve was messed up, okay, and you tell the patient, look at this side, look at my finger here, his pupils will go here, and this pupil will also go here, no problem. Why? Because at the what I told you, the right eye abducens were messed up, right? Right eye abducens. So now he's using his medial rectus to to look to this side. And from this eye, he's using his lateral rectus at the left eye. So he's able to look without a problem on the unaffected side. But if you look at your vein, it will change. What does that mean? If I tell the patient to look to this side, look what will happen. This side, the left eye, is normal, so he will be looking to this side. But this eye, it will be here. Why he cannot look here? Because abducens is messed up. Abducens is not working, which is preventing him from looking laterally. Okay? Okay. So let's discuss the next point. Ooh. The next thing is speaking about the trigeminal nerve, cranial nerve number 5. And cranial nerve number 5. First of all, I want you to understand the fact that this branch is not parasympathetic, it's more sympathetic. What do I mean by that? It's more sympathetic. Well, its nuclei don't directly hold the sympathetic fibers, but the sympathetic fibers relay into them. Okay? Relay into them. I mean that the parasympathetic will come from somewhere else, which is basically really quick. It's coming from the spinal cord, going to the paraspinal ganglia, and from there we have some nerve plexus that goes up, goes around your internal carotid, goes inside of your brain, and then it mixes up with the trigeminal nerve fiber and go out. So they want you to take home that it's mixed. Okay? It's not solely sympathetic, and for sure it's not parasympathetic. Okay, so it's for mastication, which is the muscles responsible for eating, right? So he's responsible of the movement of our jaw. Remember, guys, or don't remember, just do it now. Like the masseter muscle, which is the muscle located in your cheek, is the most powerful muscle in the body. Mastication muscle. Okay, so you have many muscles. Some of them are more important than others, but regardless, all of them are supplied by the trigeminal nerve. If you take a look here, good. If you take a look here, you can see the masseter muscle, which is the strongest muscle for mastication, and the lateral pterygoid muscle, which is help you in a crunch. But there is a muscle that is really important, which is your temporalis muscle. You're like, but this is far away from my mouth. That's true. Just right now, try to squeeze your jaw really strong, like you can feel your temporalis muscle contracting. Okay? Because temporalis muscle is considered basically the muscle of mastication. Okay? And okay, all of them supplied by the trigeminal. Mastication and facial sensation. Remember, the cranial nerve number 5 have 3 branches: the ophthalmic, the maxillary, and the mandibular. Each of them goes through a different hole. The ophthalmic goes through fissura orbitalis superior, which is this guy, right? The V2 or the maxillaris go through foramen rotundum, or the round foramen. And the last one goes through foramen ovale, which is the mandibular division. So the next thing they write here, mastication, facial sensation, so that will be ophthalmic, maxillary, and mandibulary division. And if you take a look at it here, trigeminal nerve, distribution on the face. So you can see here we have the ophthalmic, the maxillary, and mandibular. Just want to make a quick note. Notice the lips. The upper lip is maxillary, the lower lip is mandibular. Okay, good. So they write also somatosensation from the anterior 2/3 of our tongue, and also damping of the loud sound of our ear, because there is a little muscle called tensor tympani, which like let's say a huge explosion happened next to you, or some asshole started screaming into your ear. For your eardrum not to get destroyed, the tensor tympani is going to contract, which hold strong your eardrum not to get exploded, basically. Okay? And it's supplied by trigeminal nerve. You're like, wait a second, does that mean that the trigeminal nerve is having both autonomic, motor, and sensory function? The answer is yes. And I want you to make a small note. We said that it has the three branches: ophthalmic, maxillary, mandibulary. Make the following note. The ophthalmic is mainly sensory. Maxillary is mainly sensory. Mandibular is sensory slash motor. Okay? Why slash motor? Because of the mastication muscles. The mastication muscles are supplied by the trigeminal. The next one, however, is going to be the facial nerve. The facial nerve is for facial movement. The taste from the anterior two-thirds of the mouth. You are like, no, wait. You just said that the trigeminal nerve is the anterior two-thirds of the tongue. That's correct. That's somatosensation, which is pain and temperature. While the facial nerve is responsible for the taste. Taste is a more developed type of sensation. And the innervation to that area comes from a branch of a nerve called the chorda tympani. Just for a quick reminder, where did chorda tympani come from? And why does it have the word tympani? Well, basically, if you remember, the facial nerve went through the, internal acoustic meatus. In the internal acoustic meatus, after entering it, the facial nerve goes through the medial wall of the middle ear, then the posterior wall, and then exit the middle ear through the stylomastoid foramina to relieve its branches all over the face, as you can see here, right? However, there is one branch that is left, chorda tympani. The chorda tympani can go, and as you can see, this is the facial nerve. There is the chorda tympani, as you can see here, chorda tympani nerve, and it relays its innervation into the lingual nerve. You're like, wait a second, what do you mean it relays? That means that just a few branches of a nerve are going to be added on another nerve, okay? So some branches of this nerve are going to go over the other nerve, which is the lingual nerve, which is a branch actually of the mandibular nerve. Remember the mandibular nerve, V3, which was the what? The cranial nerve number 5, right? So yeah, it will go to the lingual nerve, and that will supply the anterior two-thirds of the mouth with taste sensation. Okay, the facial nerve is also responsible for urine gland. So lacrimation, salivation, all of these are supplied by it. So submandibular, sublingual glands are innervated by cranial nerve number 7. Nice. So the eye closing, orbicularis oculi. You are like, oh, you mean like the levator muscle? No, this is different. So the first one was about the fact to be able to move the eyelid up or down. That was oculomotor nerve. That's different. Now it's the ability to constrict your eye inward. It's like, you know, when you like you get out from the water after swimming and you close your eyes strongly, that's the movement of orbicularis oculi. Okay, auditory volume modulation in the stapes, which is also the stapes muscle, the smallest muscle in the body. It's also important because it also attenuates the amount of sound going to your inner ear to prevent it from destroying the hair cells of your inner ear. Just one more note about the facial nerve. If the facial nerve is destroyed, you cannot close your eyes. And if you cannot close your eyes, they can become dry, especially with the absence of lacrimation. And if they become dry, they can become infected. And if they become infected, you can have blindness. So people with destruction of their facial nerve, peripheral destruction of their facial nerve, can have vision loss eventually. Vestibulocochlear, the word vestibulo means balance, cochlear means hearing. So vestibulocochlear is cranial nerve number 8. It's responsible for the sensation of both balance and hearing. Glossopharyngeus, which is cranial nerve number 9, it's for taste and sensation from the posterior 1/3 of the tongue. It's for swelling and salivation, the parotid gland. You are like, wait a second, you told us that all of the glands in the face are supplied by the facial nerve. Yes, except of the glossopharyngeal nerve. This is really, really interesting. If you remember, which nerve goes through the parotid gland? So when the facial nerve exits, excellent, when the facial nerve exits the stylomastoid foramina, right? When it exited, it has to burst through the parotid gland. And then it has all of these branches. By the way, there is many ways to memorize the branches, guys. Well, everybody can use whatever he wants. Like there is the most common one is 2 zebras bit my cock. I will show you what that means. Don't think bad of me. So just a moment. Facial nerve branches. So there is 5 branches of the facial nerve. The first one is the temporal branch. The second one is the zygomatic, buccal, marginal, and cervical. That's where the mnemonic 2 zebras bit my cock come from. So you can memorize each branch where it goes. Okay. So it's true that the facial nerve go through the parotid gland, but it does not supply it. It just go through it. So why am I telling you this? Because in cases of parotid gland excision, the patient will have paralysis of his facial nerve. However, the destruction of the facial nerve will not lead to a problem in the parotid gland, but it will lead to problem in the other glands. The glossopharyngeal nerve is for taste and sensation of the anterior 1/3 of the tongue, swallowing as well, salivation, monitoring carotid body and sinus, chemo and baroreceptor, and an elevation of the pharynx and larynx, which help in the swallowing because it's innervate the stylopharyngeal muscle. If you remember, we spoke about the fact that there is baro and chemoreceptor located at the aortic arch and at the carotid sinus or carotid body. And we said that in case of the aortic arch, the baro and the chemoreceptor were innervated by which nerve? Do you remember? Vagus. Absolutely, vagus. What about at the carotid region? Which cranial nerve it was? This one is glossopharyngeus. Yes. Okay. So the vagus, the next one, is tasted from the supraglottic region, which is the posteriormost portion of your mouth, also help in the swallowing, the soft palate elevation. If you remember, it was everything really, really posterior in your pharynx. So it's the posteriormost area of your mouth. Midline uvula, talking, cough reflux. It's not only him, but yeah, cough reflux. Parasympathetic to thoraco-abdominal viscera. What does that mean? Well, here is the thing. Your vagus nerve is super huge. It goes through it comes from your brain. But if you take a look at the full picture of vagus, this guy is huge. So take a look. Yep. So that's your vagus nerve. It goes and it almost supplies everything inside of your GI tract until it reaches your hepatic flexure, which is pretty far away. After that, your S2, 3, 4 from your spinal cord hits in. Okay. The next thing, so as you can see, aortic arch, chemo and baroreceptor, while the glossopharyngeus used to get the baro and chemoreceptor from the carotid body. The accessory nerve is responsible for head turning, which is when somebody tap you on the shoulder and you look at him. When you do that, you are contracting your sternocleidomastoid muscle, What is your sternocleidomastoid muscle? If you right now just try to contract your neck, that's what you are doing. Sternocleidomastoid muscle contraction. So I just want to show you the muscle to be able to understand what we are speaking about. It's basically this muscle in your neck. It has two heads, sternocleidoid, so one in the sternum and one in the clavicle. Sternocleidoid, mastoideus, it means it binds to the mastoid process in the occipital bone. Okay, sternocleidomastoideus. Mastoideus. So this is the sternal head, this is the other head, and finally you have the mastoid adhesion. Also the trapezius. It's like when you ask somebody, would you like to go to eat? And he just shrug his shoulder and tell you no. That's what he did. He contracted his trapezius muscle. Okay, so here you go, guys. So yeah, turning the head, shoulder shrugging. So sternocleidomastoideus and trapezius, this is solely motor. The last one is hypoglossal. It's responsible of the movement of the whole tongue. Cranial nerve reflexes, we have the corneal reflex, in which if you bring, guys, a little like a cotton ball and you just touch the cornea of the eye, the person's eye is going to blink, correct? Why? Well, the V1 ophthalmic branch is sensory. So the nasociliary branch of the ophthalmic is going to sense, that's the afferent sensation. It will go to your brain, come back, and lead to cranial nerve number 7 working, which will lead your eye to do what? Grims, right? So the patient, after you touch his eyes, is going to close his eyes, okay? The cough reflex, let's say you got exposed to some dust or something, got into your throat, and you started why this happened? You have stimulated the cranial nerve number 10, and the response was also from 10. To make the matter worse, pharynx nerve will be involved, which will lead to contraction of your diaphragm, which will make the cough even worse. The gag reflex is when you do, if something goes down your throat that was not supposed to go there, and you start to gag it out. So that will be going, you will be stimulating the cranial nerve number 9, which is supplying the posterior portion of your tongue. You know, especially volemic, this is the linea terminalis, sulcus terminalis of the tongue. They touch this area of their tongue. Why? Because they know that it stimulates the cranial nerve number 9, which is going to lead to the stimulation of a cranial nerve number 10, which is going to lead to the contraction of the stomach, which is going to lead to them vomiting out, right? So that's how the gag reflex work. The next one is the jaw jerk. It's basically, people are awesome. So some guys was sitting and he was like, oh, there is a knee jerk. Let's try the jaw jerk. People were like, what the hell are you speaking about, man? It's like, wait a second, let me show you. I'm a professional. So basically he bring a hammer, okay? And he's going to hit somebody in his face. After such hit, she's supposed to, yeah, that's, look, there is movement, but it's not perfect. It should be much more than that. They don't show the normal. This patient is actually having absence of it, which is actually quite problematic because absence of reflexes of a patient indicate destruction of the nerve supply of that area. I mean, it's a lower motor neuron type of thing. I know that you don't know what is lower motor neuron yet, but we will get there. Lacrimation, it's what makes you cry. V1, loss of reflexes does not preclude emotional tears. Okay, so if your V1 is harmed and something gets into your eyes, you will not cry. Normally, if something gets into your eye, V1 gets stimulated, the cranial nerve number 7 gets stimulated, which makes you cry. But in case of destruction of the V1, regardless of that, you will still cry if somebody make you really sad. The last thing is a pupillary muscle. If light comes into your eye, the pupils are going to constrict by this parasympathetic cranial nerve, which is a cranial nerve number 3, the oculomotor nerve. Okay, guys. So let's take 10 minutes break, and I will see you guys in 10 minutes. Hello everyone, welcome back. So let's continue. The next thing is the mastication muscle. We just mentioned them. So let me see. Okay, I'm sharing my screen. So the mastication muscles include the following. The masseter muscle, temporalis, and medial pterygoid. You're like, wait a second. There is one more. The lateral pterygoid. Why you are not mentioning it? Well, we just mentioning the ones who close your jaw, okay? The one who close your jaw. So if this is your jaw, which jaw can move for you? Is it the upper jaw or the lower jaw? Which one can move and which one cannot move? Exactly, only the lower one can move. The upper one cannot move. So the closure is happening by the masseter temporalis and the medial pterygoid. And then there is one movement that is not mentioned. Opening of your jaw is the opposite of closing it. So if you relax these, you open it. The lateral pterygoid muscle is protrude your jaw. What does that mean? It's like the Godfather type of thing. It's moving the lower jaw forward. So it's when you move your jaw forward, this is by the lateral pterygoid. All of them are innervated by the V3, which is the trigeminal nerve, branch number 3, which is known as the mandibula. Exactly, move it forward. Spinal nerves. There are 31 pairs of spinal nerves. We have 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. The idea here that the weird one between them actually is the cervical. Why? Because at the 7th vertebra, there is 2 spinal nerves, one going over the 7th vertebra and one going under it. That's why we have 8. So nerve C1 until C7 exit above the corresponding vertebra. So, for example, if this is the vertebra, let me just show you cervical vertebra with their nerves. Nice. Okay, so for example, here you can see the C3 nerve is going over the C3 vertebra. The C2 nerve is going over the C2 vertebra. The C1 nerve is going over the C1 vertebra, and like that. This is true except for one. Take a look here at the lower portion. The C7 is going over the C7 vertebra, and the C8 is going under it. But there is no C8 vertebra. That's true. That's the point actually, that there is one extra. Okay? So as you can see here, one is going above it, one is going under it. Okay, so the C3 exits above the 3rd cervical vertebra. The C8 spinal nerve exits below the C7 and above the T1. All other nerves exit below it, so the L2 exits below the 2nd lumbar vertebra. So again, all other nerves will exit below, so the L2 will exit below the vertebra. Any other nerve under the C8 and under, they will go under the vertebra, not over the vertebra. Only C1 until C7, they go over the vertebra. Speaking of the devil, let's speak about the vertebral column. And what is a spinal tap? And well, basically lumbar puncture. It depends on your program in residency. I don't know which specialty are you interested in. If you are interested in neurology, emergency medicine, some programs of internal medicine, anesthesiology, or surgery, you must understand how this will work. Basically, we are going to discuss how to do a lumbar puncture. So what is lumbar puncture? A lumbar puncture is a procedure in which we insert a huge needle into your back with the sake of putting it into the subarachnoid space to take cerebrospinal fluid out of it and test it. It can be utilized for checking for infections like meningitis, or it can be done to check for bleeding inside of the subarachnoid space. Okay. In adults, the spinal cord ends up around L1 or L2, okay? So you will never do a lumbar puncture at this line. The subarachnoid space, however, continues. So this is the L1, L2, as you can see. The spinal cord has ended with the conus medullaris. It has ended right here, around L2. Now after that, you can see that the sac is keep going. I mean, the meninges are keeping going. So they write, subarachnoid space extend to the lower border of the S2 vertebra. So you can see it's going all the way until the S2 here. We are speaking about the sac, of course, the subarachnoid space. And it contains CSF inside of it. So, lumbar puncture should be done, obviously, under the L2. But for the sake of getting it even more safe, so this is the L2, L3, L4, L5. We prefer to do it either here or here, just far away from there. I want you to know something. In babies, the spinal cord is actually much lower. It will be like something like this. But as we get more adult, our spinal cord shrinks up, okay? It shrinks up. That's why this procedure, it's done between the L3 to L4 or the L4 to L5, only in adults. I'm going to show you a trick that you can do on your patient. So, you are a dork. Sorry, but like most of us are right now. You don't know where exactly should you put the needle. I'm confused. Where should I put the needle? Look, bring the patient and start palpating his crista iliaca. What is a crista iliaca? Crista iliaca is this thing, the uppermost portion of the bone, of your pelvic bone. So, you have palpated and sensed his crista iliaca, I mean the patient. So what to do next? The next thing is to do, like you are looking at it, you have palpated him, you know what is his crista iliaca, make a line between the two crista iliaca. So this, you palpated it here, and you make a line, straight line. Then start palpating his vertebra and go down. The point at which these two cross together, this is exactly where you should put the needle, okay? Again, palpate crista iliaca, make a imaginary line. Start palpating the processus spinosus, which is a projection of the bone located at the posterior portion of the vertebra. Where the two lines go together, make your puncture there. When you do the puncture, you need to sense it, you need to feel it. Act with it as a gentle lady or gentleman or a lady. What do I mean by that? Do not put it quickly. You will insert the needle in a really, really slow fashion. You are like, but it's a huge needle and it's really painful. I agree. That's why you should use local anesthetic. The next thing is goal of lumbar puncture is to obtain a sample of the CSF without damaging the spinal cord. To keep the cord alive, keep the spinal needle between L3 and L5. Okay, yeah, because you should not touch the L2. Anyway, now I'm passing the needle slowly. I go through the skin, fascia, subcutaneous fat, and next, the supraspinosus ligament. Okay, what is that? The supraspinosus ligament is the ligament going over the vertebrae. So I'm just putting my needle here, right? So, it's the supraspinosus ligament is here. The next thing I'm going to go through is the intraspinosus ligament, which is the ligament located between the vertebrae. And the next thing is going to be ligamentum flavum, or the yellow ligament. It's located at the posterior most part. They always test about this one. What I want you to know, that the moment you go through the posterior, through ligamentum flavum, you will feel a huge resistance. Ligamentum flavum is pretty hard. So when you go through it, you will feel a resistance. You will feel like you are pushing something hard. Okay, and after that, this will go away. Why it went away? Because you are already in the epidural space. So far, how many resistance you have felt? One strong resistant only, okay? you have felt only one strong resistant. After one strong resistant, you can give epidural anesthesia in a pregnant lady. Why do we give it? To facilitate the delivery. Guys, I mean, come on. Is delivery painful? Is labor painful? Obviously. It's really painful. I mean, I was reading something, it's like, yeah, anyway, it's painful. And basically, the epidural anesthesia reduces the pain significantly. Well, does that mean that it will remove the pain 100%? Not truly, but the lady, instead of having this shearing pain, feeling like somebody is stabbing her with multiple knives inside of her pelvis, she will feel the pressure. She will feel the pressure, she will feel the contraction, she will feel it all. But she will not feel tearing pain. She will not have this sensation of that she's going to die in 2 seconds. So yeah, it is a good deal. Does it have complication, the epidural anesthesia? Does it have complication? Yes, it does. For example, if the person giving the anesthetic is stupid, and when he reaches the epidural space, what is the first thing to do? You have the medication, you should push it in, correct? Right away, without checking anything. Just put the medication and push it in. No, you should not push it in. You should aspirate. When the needle is inside, try to aspirate. Suck the needle. Why? You need to make sure you are inside. If you suck the needle and the blood comes out, should you inject anything? No way. You are inside of a blood vessel. If you inject the anesthetic, it will go directly to her heart. Her heart will stop. That's not smart. That's why it's done mostly by a specialist, not by general doctor. Okay, so you aspirate. There is nothing, you push in the anesthetic, she has no pain in her lower extremity anymore. She cannot move them, but who cares at this moment? She has no pain. That's the point. That's what you wanted from her. You don't want her to go around. So, good. Let's say that that's not why you did the lumbar puncture for. You done it for something else. Okay, screw the thing you wanted to do. Let's keep going. We keep advancing with the needle. Now you will feel a second huge resistant. Okay? The second huge resistant, we call it the dura mater. Remember, dura is durable. It means it's strong, it's hard. Dura means hard. This is the second resistant. So for the anesthetic, you feel one resistant. But for basically CSF sampling, you have to feel two resistant. Then you reach the arachnoid matter, it will not be that thick, and then you will feel the subarachnoid space. You take some blood, okay? What I want you to understand about this CSF collection, you don't take one tube, you take 4. Let's say that in your 4 tube, the first tube had blood in it. The second tube has a little bit of blood in it, and the rest was CSF, of course. The third tube is clean, the fourth tube is clean. Does that mean that this patient has a brain hemorrhage? Excellent. It does not mean that he has a brain hemorrhage. Basically, this is an artifact. It's from your needle bursting some blood vessel throughout the way. But if you do the test and the first tube is full with the blood, second tube is full with the blood, third tube is full with the blood, fourth tube is totally full with the blood, does that mean that this patient has subarachnoid hemorrhage? Yes. Okay, good. That's why we take 4 tubes, not 1. Good. That's the CSF. The next thing we are going to speak about is going to be the spinal cord and its associated tracts. Each tract in the spinal cord has a totally different function. So the legs are lateral in the... so wait for that statement. For speaking about it, I want just to speak about general area and then go to speak whatever they write here. Okay, guys. A tract is a collection of what? What is a tract? It's a collection of axons. What about a nucleus? A nucleus. Yes, that's correct. Nice. Okay. So in the spinal cord, you can see the following area. This is the posterior column. This is the lateral column. This is the anterior column. This is the anterior horn. This is the lateral horn, or they like to call it intermediolateral horn or lateral horn. This is the posterior horn, okay? This resembles a butterfly. Some people say it resembles letter H in English. Doesn't matter. It's white matter, right? Because, I'm sorry. No, I just made a mistake. It's actually a gray matter. Gray matter, why? Because it's full with bodies of the neurons. While all of the other the tract, which is the white matter, it's going inside of the columns, right? The first one that they always tell you about is the spinothalamic tract. The spinothalamic tract, it's a sensory and it's for pain and temperature. The info will come from the posterior horn, and then after doing that, it will go through the anterior white commissure, right? And then it will keep going until it reaches the lateral spinal thalamic tract and goes upward. Okay, what about the anterior one? Yes, that is also possible, and this is more likely to be for a crude touch. Remember, there is a crude touch and there is something known as fine touch. Fine touch will be posterior column. Crude touch will be anterior spinothalamic tract. So let's try to elaborate on that. All type of sensation are mediated by the anterolateral system. Anterolateral system basically means a really old system responsible for all sensation. All sensation include one, a patient pain, temperature, and a crude touch. Pain, temperature, and a crude touch. Good. So if we speak about the other thing, which is the posterior column, this is the more modern type of sensation. That will be for proprioception, vibration, and stuff like that. New stuff and fine touch. So, like the homunculus in the brain, there is a homunculus in the spinal cord. So the legs are lateral in the lateral corticospinal tract and the spinothalamic tract. The thoracic spinal cord section can be seen here. So if we speak about the lateral corticospinal tract, the corticospinal tract should be right here, while the spinothalamic tract should be here. So when we are speaking about the legs, they will be to the outside, basically. The legs are to the outside, while the hands are to the inside, like this, okay? And both of them. So this is hand, this is legs. The dorsal column are organized as you are, with hands at your sides. So the idea here, guys, to make it more like easy for you, the posterior column is actually, it's like a pizza, a four-sided pizza. So you can see this is for your left side and this is for your right side, right? So this is for your legs, this is for your hands and arms. The idea is, if I do a cross section of the spinal cord at your sacral or lumbar area, will you see the hand area? The answer is no, you will not be able to see it. You will only see the leg area. They do have actual names, I will not say them now. But in general, you will not see the hand area at the lower portion of the spinal cord because it's not there yet. But when you go at the thoracic level, the fibers of the hands started joining. And that's why they are located laterally to the legs. Okay? Good. So, in general, let's just take one portion and just make our pizza really quick. So, here we have the legs here, we have the hands here. But in this area, it's kind of different. Yes, okay, so we have the legs here and we have the hands here, okay? Just keep that in mind when we discuss all of this stuff. Good. So here you can see that, oh yeah, the You can see the more lateral you go, the more up you go. I mean, the sacral comes first, then the lumbar, then the thoracic, and lastly the cervical. This area comes from the ground, right? I mean from the legs, ground. Why I keep saying ground? Gracialis, oh, that's why. Ground gracialis, okay? So the dorsal column is for pressure, vibration, 5 touch, and conscious proprioception. Proprioception is the sensation of your limbs and your basically joints and muscles in the space. Without opening your eyes, you realize where exactly, just close your eye, put your hand on the sky, just rise it up, and just imagine, where is my hand? You can exactly imagine where it is. Move your finger and touch your nose. You did it, because your proprioception is intact. Okay. Fasciculus gracialis comes from your lower body and the legs, while the cuneatus comes from the upper body and the arms. And the next point is, oh, you can see the gray matter, it's body of the neurons, while white matter is the axons. You can see also as well here the anterior spinal tract. Anterior spinal tract, it has 2 subdivisions. We have the lateral and we have the anterior. That's why they call it the anterolateral system. The anterior one is for crude touch and the pressure. Okay, crude touch is like somebody pushing you guys. Fine touch is like somebody just putting his hand on your hair and telling you everything will be fine. Yeah, that's fine touch. Lateral spinothalamic tract is for pain and temperature. So you can see the sacral area here and the cervical area here. Or just to make it simple for you, remember what I just told you? Legs, hand. That's enough for you. Okay. In this area you can see the descending tract, the corticospinal tract. Again, it also has an anterior and also has a lateral. However, it's not the spinothalamic, it's corticospinal. So it's something descending. So it's for movement. Okay, so both of them are for voluntary movement of some movement that you do. But again, remember, hands medially, legs laterally. Okay, good. So these are the different tracts that are located in our spinal cord system. So let's speak about each system of these and how does it work. The spinal tract anatomy and its function. Ascending tract, synapse, and then cross. What? Well, I will explain. So when we speak about spinothalamic tract, for example, I don't like the picture they show, so I would like to find one online. So spinothalamic tract. Spinothalamic, so it should come from the spino, which is low, to the thalamic, which is up, right? Spinothalamic, makes sense. Okay, so let's try to understand how does this process occur. Come on, come on, come on, come on, come on, open. Okay, good. So they draw for us here how the first neuron is located at the posterior ganglia, and then it's for the brain, of course, and then it enters the substantia gelatinosa, which is basically the posterior horn, and at the posterior horn it has synapsed. Oh, so that's the first synapse. So they said it's synapse and then a cross. Okay, so synapsed and then it's going to cross. What is this structure called, guys? It's a crossing gap. Has a name. I will give you a hint. It was the first structure to be destroyed in case of syringomyelia. It was anterior commissure. Okay, anterior commissure. So through the white anterior commissure, it goes like this, and through the anterior lateral spinothalamic tract goes up. See, it's not synapsing yet, it just synapsed once. Up. It will synapse again in the thalamus. Ooh, okay, so the first neuron is here. The second, so first neuron, second neuron, and third neuron. So it's a 3 neuron system. One in the posterior column, one in the posterior ganglia, dorsal ganglia, one in the posterior horn, and one in the thalamus. three neurons system, right? 1, 2, 3. All of the sensory pathway have three neurons. All of the motor pathways have two neurons. So if I'm going to Google next, dorsal column pathway, dorsal column tract basically. What do you think? Is it two neurons or three neurons? It's going to be three because it's sensory, guys. Sensory. Sensory is a 3, motor is 2. Sensory is a 3, motor is 2. So speaking about the dorsal column, let's take a look. No, not this one. Okay. Oh, but bad picture, so I'm hoping for something better. Come on. So let me see. Okay, that will do it. So these patients are going to have the following. Their first neuron is going to be at their dorsal column. I mean the dorsal system. So dorsal column. After that, it's going to enter, and after it enters, it's going to go up until it reaches the nucleus cuneatus and the nucleus gracialis. Okay. So wait a second, go back for me. You did not say anything about binding or synapsing in the spinal cord. Does that mean that the dorsal column does not synapse in the spinal cord? The answer is yes. So from the dorsal column, it's going to go directly up until it reaches the nucleus cuneatus and the gracialis, which are located at the lower portion of the medulla oblongata. At the medulla oblongata, these nuclei are the second neuron. And from the second neuron, anytime you have the second synapse, what do we have? Relaying to the other side. So the dissociation and the passing to the other side is going to happen now. So it's going to the other side, and the third neuron will be located at the thalamus. Okay, guys? Good. So here you go. Again, sensory. How many neurons in sensory, guys? Sensory, how many neurons? Any sensory system is going to be 3 neurons. End of the story. Any motor system, doesn't matter which one. How many neurons? Motor, 2. That's it. 2. Okay, good. So when do we have the dissociation? Always after the synapse. When you synapse, you will have the dissociation after it. I mean, the sensory thing. See, he synapsed here the first time, dissociation, which is meaning passing to the other side. Synapse here, passing to the other side. Okay, good. So that was the spinothalamic and the dorsal column system. So the dorsal column is responsible for the pressure, vibration, fine touch, and proprioception. All of these are relatively modern type of sensation. Sensory nerve ending will go and bypass the pseudo-unipolar cell body in the dorsal root ganglia. You're like, okay, I understood only dorsal root ganglia, but what is this pseudo-unipolar cell? Well, pseudo-unipolar is a shape of a structure. So pseudo-unipolar, it's one type of neurons. It's one shape of a neurons. The the pseudo-unipolar neurons basically just look weird. So they look something like this. See? It looks like they have just one exit, but look what they do. Exit and then divide to 2 sides. Damn it. So they do have 2 axons from 2 sides. That's a pseudo-unipolar. Okay. So this pseudo-unipolar is located at the dorsal root ganglia. And after that, that is considered to be the first neuron, right? After that, it's going to enter to the spinal cord. It will not synapse. It will not synapse, I repeat. And is going to ascend ipsilaterally in the dorsal column. In the dorsal column, remember, the legs goes laterally, the hands goes medially. I'm sorry, the hands goes laterally, the legs goes medially. So the legs are going to be medially, that's gracialis. Oh my God. The legs are going medially, that's gracialis, while the hands are going laterally, which is cuneatus. Okay? So they will keep going until they will reach the nucleus, cuneatus, and the gracialis, which are located at the lower portion of the ipsilateral medulla. And the moment they bind to it, remember, we synapse and go to the other side. So synapse and the second order neuron will dissociate in the medulla and ascend contralaterally as the medial lemniscus. You're like, okay, I got some of that, but there's something I'm not getting it. What is medial lemniscus? Well, medial lemniscus is a system that helps you to move between two areas. Think about it like the anterior commissure. Okay? So it's a relay station, it's a train station that help you to move from area A to area B. So what's up with that? Okay. Media. Okay, so it's a white matter structure that goes from the like from one side to the other side, as you can see here. So this is the medial lemniscus. This is a gracialis and cuneatus and nucleus, and after the dorsal column tract bound to them, it moved them through the medial lemniscus system to relay them to the other side. Okay, so now after the dissociation happened, medial lemniscus took them all the way up to the thalamus. Okay, good. In the thalamus, they will reach the VBL. Remember, the VBL, it was for both of them, anything that comes from the body. VBL, and then to the sensory cortex, which is located at the post-central gyrus. Spinothalamic tract, we have two areas. We have the lateral and we have the anterior. So the lateral one is for pain and temperature, while the anterior is for a crude touch and pressure. More of a crude touch. It's like somebody pushing you guys. Sensory nerve ending, alpha, delta, and C fibers. Remember, the C fibers are it's like a taxi, it's slow. While the alpha delta, it's like a delta airplane, it's quite fast. Yeah, it bypasses the pseudounipolar cells again in the dorsal root ganglia and enters the spinal cord. So the first order neuron is located at the posterior root ganglia. The second order neuron, where it will be? After going to the spinal cord, the ipsilateral gray matter of the spinal cord there at the posterior horn is located your second order neuron. So then you will dissociate in the spinal cord himself using the anterior white commissure, which is affected by which disease? Which disease is the most common disease to lead to the destruction of the anterior white commissure? Syringomyelia. What is BH? Syringomyelia, guys. Syringomyelia. So, after that, it ascends contralaterally to the other side, basically. Okay, good. And after going to the other side, it will reach the thalamus, and from the thalamus to the post-central gyrus. The descending tract, however, is quite interesting as well. Let's take a look at how it looks like. Corticospinal tract. So corticospinal tract, its motor, how many neurons it will have? Excellent, it's 2. You did not even have to look at it. So, the corticospinal tract, it's quite interesting actually, I have to say. So this guy is going to come from the motor cortex, which is located at the precentral gyrus, and then it will go down and it will relate to the other side after it goes near the basal ganglia, or sometimes the relay actually going to be inside of the brainstem himself. So at the level of the brainstem, the relay is going to occur. Let me find a good picture of that actually. Nice. So you can see how it's coming down. The first order neuron is located at the brain himself. It will keep going and it will bypass to the other side. You are like, wait a second, but you told us the moment we synapse, we only dissociate after we synapse. That's true for the sensory things, not for this one. For this one, you will keep going and you will synapse later, because only two neurons, there is no need to synapse a lot. So the first neuron is there, the second neuron is at the anterior horn after pyramidal dissociation happened. Pyramidal. So when they say that the pyramid of the medulla are affected, what are the pyramid? Pyramid are collection of fibers that are made of corticospinal tract. So you can say that the pyramids of the medulla oblongata are equal to corticospinal tract. Okay? So when the pyramid of the medulla are affected, you have destroyed the corticospinal tract. Good. Nice. The next thing we have here is like they write, it's going to go to the anterior commissure and then ascend contralaterally to reach the postcentral gyrus. We finished with this one. Oh, now we speak about the corticospinal tract. Yes, voluntary movement of the contralateral limb. Limbs on the other side. The upper motor neuron is located at the primary motor cortex in the postcentral gyrus. Remember that the legs are located medially while the arms are located laterally, and the face is located laterally as well. On the homunculus, I mean. So if this is the brain, the legs will be here, the hands will be here, right? And the face will be here. Actually, the hands may be here. Hands will be here, and the face will be here. Okay, so, oh, nice picture. Okay, so they write, cell body in a primary motor cortex will lead to a descent ipsilaterally through the posterior limb of the anterior capsule. Like, what is internal capsule? Internal capsule is a collection of white matter located between the cortex and your basal ganglia. So this internal capsule is basically a white matter collection. And then it goes through the cerebral peduncle. What is cerebral peduncle? So many new terms. So let's take a look at this and try to understand what is all of that. So that's the precentral gyrus. The axons came from it. They are passing through the internal capsule. The white stuff is the internal capsule. Then they are reaching, wait a second, there's this, oh, this is wrong. I was like, no, it's not this thing. Okay, so that was wrong. This is right. Let's take a look. Okay, so you are going from the primary motor cortex. You are going through the white matter, which is the internal capsule. You keep going through the midbrain, this portion of the midbrain, which is known as cerebral peduncle, or the feet of the brain. Then you keep going through the lateral bones, and you keep going until you reach the dissociation at the pyramid of the medulla, which contain the corticospinal tract, until you reach the anterior horn of the spinal cord. That's the take home. Okay. Most fibers dissociate at the caudal medulla, pyramidal dissociation, and they descend contralaterally after that. Cells body of the second motor neuron are located at the anterior horn, and we call them lower motor neuron. Lower motor neuron will leave the spinal cord in a form of a spinal nerve. Neuromuscular junction will form, and that will go to the muscle fibers. Neuromuscular junction has an acetylcholine receptor, nicotinic receptor actually. So the neurotransmitter is going to be acetylcholine, but the receptor is going to be a nicotinic receptor. Nicotinic receptor are not a G-coupled type of receptor. No, they are ion channels, which promote the sodium to come inside of the cells, and that is going to lead to the contraction. The next thing is going to be about clinical reflexes. So reflexes count up in orders. I know, guys, this sucks, and I personally hate it, but you have to memorize it. Really, they do ask about it. So yeah, the Chialis reflex is going to be S1, S2, buckle my shoe, if it works for you. Patellar reflexes is going to be L2, L4, kick the door. L2, L4, kick the door. Sounds like rap. Okay, biceps reflex is going to be C5, C6, pick up my sticks. That's stupid. Okay, so triceps reflexes is going to be C6, C7, C5, lay them straight. I don't know, that just does not work for me. It does not go. Cremasteric reflex, however, is pretty interesting. It's when you have a man, for example, if you just touch his inner thigh from here, his testicles are going to go up. This is super important to diagnose if this patient in front of you has a torsion of his testicle or not. If a person is suffering from a torsion of a testicle, cremasteric reflux will be absent. So always check for it in a patient. Or if you are a man, you can check for it without being a patient. So just stroke the inner portion of the thigh and the testicles will go up, okay? Anal wink reflux is when you touch the anus, it's going to close on itself. Yeah, that's S3 and S4. Some person told me about a mnemonic. I don't know if it will work for you. It's a dirty one, but I have to share it with you. So it tells a story. It's like a Cinderella-like story. If you don't want to ruin your childhood, just mute me for 4 minutes. The idea is something like this. So a prince goes to a party, 12 o'clock at night. Cinderella is dancing there. So he danced with her. He held her arm, and he's holding her arm, and he stretched it in and out. So he flexed her arm, and this is the only thing you have to memorize. He flexed her arm during the dance. Flexing her arm, that was C5, C6. Okay, so I had to memorize only C5. C5, C6. Good. Well, after he flexed her eye, he's going to extend her eye. Always keep the last one you just spoke about. So we said C5, C6. Now, extending her arm will be C6, C7, C8. Okay? So, this type of things, always keep the last one and add one. That means, so C5, C6, now C6, C7, C8. So you kept the previous one and you added one. Okay. So after that, they were still dancing. What comes after C8? Remember, the thoracic vertebrae are not involved. So you have to go directly to the L's, right? The man felt something weird. He felt his cremasteric reflux working. That's L1, L2. So yeah, C5, C6, C7, C8. We don't consider the thoracic to exist. Forget about them. Go to the next thing, L1, L2. L1, L2, the man while dancing saw that his cremasteric reflux was going, and he was confused. He did not understand what happened. So he looked down there and he saw Cinderella using her patella to induce that reflux. So that was L2, L4. L2, L3, L4, right? L2, L3, L4. Okay? Because this here we said L1, L2. You keep one and you add one. So it becomes L2, L3, L4. So he was weirded out by her, and he did not know what to do. So he stepped back for a second, and she felt so shy of what she did. So she ran away. And when she ran away, she dropped her shoe. Dropping her shoe is the Achilles reflex, right here. So that will be the next one. So we said already about L1, L2, L3, L4. The next thing is going to be S1. So the Achilles reflex was S1, S2 when she lost her shoe. So he kept looking for her years and years until he finally found her, and he checked her anal wink reflex. S3, S4. That's the story about Cinderella and the reflexes. If you like it, you like it. If you don't, it's okay. It's just somebody told it to me. It's stuck in my brain. I could not forget about it. That's how I know all of the reflexes. So, reflex grading. The normal thing is to be +2. If it was 0, that means no reflexes. It's a lower motor neuron symptoms. You will know what that is later. 1 is hyporeflexia. 3 is more. Clonus is 4. Clonus is a massive amount of movement. It's crazy. The next thing is going to be primitive reflexes, but before speaking about the primitive reflexes, let's just take 7 minutes break. So see you guys in 7 minutes. Let's finish up physiology of the brain. Yep. So actually the pathology of the brain is much more easier than the physiology of the brain. Physiology sucks, always. So primitive reflexes. They are some form of reflexes that exist in a baby. They don't exist in us adult. Why? Because they have disappeared. Basically, I want you to understand why they occur in the first place. They are an upper motor neuron symptoms. What does that mean? Remember the motor neurons? Sorry, the motor tracts involve two neurons. Upper neurons, tract, lower neuron, and then more axons, and then you reach a muscle, right? Okay, so what I want you to know, in general, that the upper motor neurons are inhibitory. The lower motor neurons are stimulatory. So it's like a stupid kid. The lower motor neuron, which are these ones, are stimulatory. They are young and crazy. Upper motor neurons are old and wise and know exactly what they are doing. They always try to inhibit the stupid kid down there. So if the person will have an upper motor neuron lesion, so the upper motor neuron itself, the body is destroyed, or the axon of it is destroyed, the patient is going to develop what? Hypo or hyperreflexia? What do you think? Hyper, obviously. Okay, if on the other hand, the lower motor neurons were destroyed, either the nucleus or the axon, what is going to happen to the patient? Hyporeflexia. Good. If that makes sense, we are moving in a good situation. So, in babies, they don't have normal myelination of their axons yet. Why? Because they are still babies. They need some time for their axons to develop. This is absolutely correct for the corticospinal tract. So this is the corticospinal tract. So if it's demyelinated, it will be inactive, the upper motor neuron. So which symptoms do you think the baby will have? Will it be hypo or hyperreflexia? This is demyelinated. Hyperreflexia. Okay. Do you have a proof for that? I do. So let me just take a look at a baby. No, not this one. So that was a okay. So let's just take a look at a newborn, not a baby. Need to be careful these days. Okay, look at this baby. Is he having hyperreflexia or hyporeflexia? What do you think? Look at his hands. Look at his leg. Right? That's hyperreflexia. And why is that? Because his corticospinal tract is still demyelinated. Is that normal? 100%. Look at him. Hyperreflexia. That's normal. Oh yeah. The problem is for if the person is having the opposite, basically. I mean, if it's a baby and he has a plasticity, which is like hyperreflexia, that's problematic. The baby should have hyperreflexia. This is one of the things we actually test for, that the baby must have hyperreflexia. Okay, good. So they write CNS reflexes that are present in a healthy infant but are absent in a neurologically intact adult. So in us, adult, they disappear. Why? Because until 1 year of life, we myelinate all of our corticospinal tract, so all of these symptoms will disappear. So normally disappear within the first year of life. These primitive reflexes are inhibited by a mature developing frontal lobe with full myelination and corticospinal tract full with myelination. Do not forget, please, that the corticospinal tract does start from the precentral gyrus, which comes from the frontal lobe, the motor cortex. They re-emerge in adult following a frontal lobe lesion, which will lead to loss of inhibition of these reflexes. Why loss of the inhibition? Because the upper motor neuron lesion, basically. Motor reflux. What is the motor reflux? It's quite cool, but I really like to show videos for each of these reflexes. So the motor reflex goes something goes something like this. Come on. It's taking some time. Okay, let me just explain it to you how we do it. The baby is, you have the baby, okay? You have a baby in your hand. What to do with him? Put him on like some type of table, okay? Then let him go. Of course, not far away. It's like on his bed. And you just raise him a little bit like this and let him go. So when he drops, he's going to open both of his arms, okay? and abduct him away. That's a motor reflex. That's absolutely normal, of course. So when you see that, don't worry, it's normal. There is multiple ways of doing it, by the way. This is one way, which is like throwing him to the bed.
You can elicit the Moreau reflex by having him relax, unsuspecting, and then give him a sudden stimulus, and there's a good Moreau.
Open his hand.
Quiet, and headlock midline, and then just give the stimulus of dropping him back a few inches, and that's a good Moreau.
Okay, good. So guys, by the way, if you bring a baby, throw him in the water when he's like maybe, I don't know, he's really little baby, like 8 months old baby, and you put him in the water, can he swim? Or even younger, let's say 5 months. He can. I know it's weird, but we are born able to swim, but we forget. Okay, so the next one goes something like this. Rooting reflex. It's basically like if you put if this is the baby and you put something here, he's going to move his mouth towards it. Why? Because he thinks it's the nipple and he want to suckle on it. So yeah, movement of the head towards the side. If the cheek or mouth are stroked because of the nibble seeking, he's looking for the nibble to suck. If you put something inside of his mouth, it doesn't matter. Your thumb, the nibble, doesn't matter. He will start suckling on it. So that's the sucking response when the roof of the mouth is touched. The palmar reflex, curling of the finger, is curling of the finger if palms is a stroke. Basically, just bring his hand, bring your pen, put it inside of it, he's going to grab it. Okay? Plantar reflex is a dorsiflexion of the large toe. So if this is the feet, and you do something like this, you stimulate it, there will be dorsiflexion of the large toe and fainting of the other toe with the plantar stimulation. So you just bring a pen and stroke it like this. The big toe, this one, will go to this side. The other ones will go to this side, anterior ward basically. Well, plantar ward, and this is dorsal ward. This is a positive Babinski sign. Babinski sign is completely okay in a baby. In an adult, however, it's an upper motor neuron lesion. Presence of this reflex in an adult, which may signify upper motor neuron lesion. Galant reflex, which is the last one, it's a stroking of one side of the spinal cord, of the spine, like here, okay? While the newborn is in ventral supination, basically he's laying on his tummy, will lead to a lateral flexion of the lower body towards the stimulus. Basically, he's like this, right? You stroke this area, this patient is going to move to this side, okay? If you stroke this area, the patient is going to move to this side. Good? You just bring your finger, pass it through this, and he will move to this side. If you do it to this side, he's going to go to this side. That's galant reflex. Again, plenty of stuff to memorize. Some of them you know already, some of them you don't know. Basically, when you look at this picture, it does not make sense why C5 is here and why C2 is here. I mean, really, it does not make sense. So C5 is here, while here it's L4. It does not make sense. I mean, how did they did the distribution? If you understand how they did the distribution, it will make sense. Basically, the guy who discovered all of these in the beginning, he did not do it in a human. He did it in a dog. Okay, we are getting somewhere. Yes, he did it in a dog. So when you check out the dermatomes, you should not imagine somebody standing on his legs. You should imagine somebody doing something like this. Now it will make sense. C2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. And like just you are counting numbers of the segments of the spinal cord. If you imagine the patient laying like this, 4 legs, because the person who discovered all of this did it in a dog, not a human being. That explains why the C5 is the last thing at the butt here, and the C2 at the head. Okay, so let's take a look. The C2 at the posterior half of the skull. The C3 is like right here. It's like the shirt. This doesn't matter. The most important thing to know that it supplies the phrenic nerve. So C3, C4, C5 keep the diaphragm alive. This is one of the take-homes. C4, they say low color shirt. They will not ask about that. The next one is the C6, which is for the thumb. They do ask about that. I personally imagine number 6 here, okay? Or number 6 here, okay? So they do ask about the thumb. So yeah, thumbs up look like number 6. The T4 for the nipples, they do ask about that. And the T7 for the exiphoid process, which is at exactly right here, and which is the end of your sternum. T10 is for the umbilicus. They do ask the umbilicus one, and they, if you remember, we had early appendicitis sign, peri-umbilical pain, and the late appendicitis sign, which is right lower quadrant pain. The early signs were due to visceral innervation affection, which is by T10. Late manifestation was because somatic innervation supplying the parietal peritoneum, and it only can occur if the parietal peritoneum is affected. L1 for the inguinal ligament, and the L4 is for the kneecaps, basically. And finally, S2, S3, S4 basically is sensation of the pineal, which is the penis, and the anal zone. Okay, L2, L3, S2, S3, S4 keep the penis off the floor. Okay, so it helps in the erection. Before I move forward, the last, okay, that will be it. But before that, I just want to explain the last point about erection and ejaculation. There is sympathetic and parasympathetic nervous system. The sympathetic nervous system is responsible for the ejaculation. The parasympathetic nervous system is responsible for the erection. So if the man is in a stressful situation, can he get erection? No, he cannot. That's why we call that a psychogenic impotence. If the man feels like, his partner is kicking his ass or something like that, or he feels really bad in the relationship, he will be unable to get an erection. If he feels so stressed because of work or stuff like that, he will be unable to get erection. If he has a mortgage to pay or something like that, he cannot get an erection. So, because of that, the parasympathetic nervous system is responsible for the erection. However, during sex, his parasympathetic should work. But at some moment during the sexual activity, the whole parasympathetic is going to shift into sympathetic suddenly, right? So the ejaculation happened because of the sympathetic. So how can I remember that erection, it's parasympathetic, and the sympathetic is ejaculation? Somebody told me once, point, it's like erection, pointing, and shoot. Shooting is the ejaculation. Point and shoot, parasympathetic erection. Shooting is sympathetic for ejaculation. Okay guys, thank you so much, and we will continue our work tomorrow. We're finally done with the physiology. The moment in the CNS, every single time we finish the physiology, everything after it becomes a piece of cake. So good, we are done with the physiology, and I will see you guys starting our first class of pathology. Goodbye everybody. Thank you.